Good morning, everyone. Welcome to the presentation. This is a case presentation of Parkinsonism. So, today I am presenting a case. The patient is Chetan, a 52-year-old right-handed male patient from Dharwad. He has studied up to second PUC and was previously a kabaddi player. He was admitted on 5th of August 2026 and was examined on 8th of August 2026. The history was obtained primarily from his wife, who is a reliable informant because of patient's significant motor and speech impairment. Chief complaint: patient presented with severe constipation and difficulty in micturition for 4 years, progressive slowness in activity for 3 years, and stiffness involving all 4 limbs for 3 years, and progressive difficulty in speech for 3 years. In addition to these, he subsequently has developed gait impairment, postural instability, freezing, dysphagia, and progressive dependence on others for his daily activities. Coming to the earliest neurological symptom was severe constipation, which began approximately 4 years before the admission. Patient would pass stools only once in every 6 to 8 days and required prolonged straining, sometimes for 1 to 2 hours to achieve normal bowel evacuation. There was no associated abdominal pain or fecal incontinence. The severity and early onset of the constipation occurring before the development of prominent motor symptoms are important clues towards underlying autonomic neurodegenerative disorder. A few months after the onset of this constipation, patient developed a progressive difficulty in passing urine. Although he continued to have a preserved sensation of bladder fullness, he required severe straining to initiate urination and could pass only small amount of urine at one time. He also developed increased urinary frequency, passing urine every 1 to 2 hours. On 3 occasions, the urinary retention became severe enough to require catheterization, although there was partial improvement with medication. His urinary dysfunction persisted, and later gait impairment and urgency resulted in his being managed with a quantum catheter. The combination of urine retention, poor urinary stream, frequency, urgency, it presents significant autonomic dysfunction. So then patient also had a history of erectile dysfunction for approximately 10 years. This symptom actually preceded the onset of other neurological manifestation by several years. In the context of subsequent severe urinary and bowel dysfunction followed by Parkinsonism, long-standing erectile dysfunction provides additional evidence of significant autonomic involvement. Approximately 3 years before this admission, his wife noticed a progressive slowness in his day-to-day activities. He became increasingly slow while dressing, while brushing, eating, and performing other routine activities. Over the following years, the slowness progressed to the extent that he required assistance for essentially all the activities of daily living. This was accompanied by progressive stiffness involving all the 4 limbs, initially affecting the upper and lower limbs and subsequently extending to the neck and the trunk muscles. The rigidity was symmetrical and progressively involved the entire body. Initially, the 4 limbs were affected, but approximately 1 year later, the neck and trunk muscles were also involved. The axial rigidity became severe enough to interfere with sitting cross-legged, turning in the bed, lying on one side, wearing the clothes. This prominent early axial involvement, together with severe autonomic dysfunction, It's an important atypical feature of this case. Gait difficulty began around the same time as bradykinesia. Initially, the patient walked slowly and had difficulty in lifting his feet adequately, frequently stopping while walking. Subsequently, he developed a hesitation during gait initiation and freezing, particularly while particularly while approaching doorways and reaching obstacles. Turning became increasingly difficult and required multiple small steps. He developed a tendency to fall backward and eventually required physical support from another person while walking. As these disease as these features progressed, prominent axial postural abnormalities developed. He adopted a forward flexed posture and subsequently developed a forward flexed posture over the 1 year. On examination, antiquolis and Pisa type lateral flexion were also present. He was unable to maintain his posture independently and would sway anteriorly and laterally when unsupported. These severe axial and postural abnormalities occurring relatively early in the disease are characteristic of atypical Parkinsonism. Patient also had fine motor activities progressively becoming more difficult. He had difficulty in holding the mug, reaching for an object above his head, combing the hair, buttoning and unbuttoning the clothes, and mixing the food. He also had difficulty turning over in the bed. His handwriting progressively became smaller, consistent with micrographia, and eventually he had severe difficulty even performing his signature. These symptoms reflect marked bradykinesia affecting both gross and fine motor functions. Over the same period, his speech became progressively slower and softer. His wife noticed a reduction in spontaneous speech output, reduced voice volume, and progressive loss of facial expression. On examination, he had hypomimia, reduced blink rate, hypophonia, hypokinetic dysarthria. Despite the speech impairment, comprehension, repetition, naming, reading remained preserved, indicating that the primary problem was motor speech dysfunction rather than cortical language disorder. During the later course of this illness, patient developed difficulty in chewing as and dysphagia, particularly for the solids, for approximately 1 year. He experienced episodic choking while eating. However, there was no nasal regurgitation, excessive drooling, or significant spillage of food. The development of bulbar dysfunction in association with severe Parkinsonism and autonomic failure further supports multiple system neurodegenerative disorder. Negative history. There was no history suggestive of an alternative cortical, cerebellar, or sensory syndrome. Patient and his family did not report significant memory impairment, behavioral changes, visual hallucinations, delusions, emotional lability. There was no visual disturbance, numbness, paresthesias, impairment of temperature sensation. There was no history of vertigo, limb incoordination, loss of consciousness. There was no fasciculations or significant muscle wasting. Importantly, there was no history of REM sleep behavioral disorders, although daytime sleepiness was reported. Past personal and family history. There was no history of head trauma, toxin exposure, diabetes mellitus, hypertension, or previous cerebrovascular disease. He was previously an active sportsman and had no history of smoking, alcohol consumption, or tobacco chewing. He had a mixed diet and had experienced weight loss despite preserved appetite. There was no family history of similar neurological illness or premature death. He was born to second order non-consanguineous marriage. His father had suffered cerebrovascular accident and died at the age of 78, and his mother is currently alive and is 76-year-old. Patient had received allopathic treatment for his slowness of activity and urinary retention for approximately 1 year, but there was no significant clinical improvement. He subsequently received Ayurvedic treatment for around 2 years. Despite treatment, disease continued to progress. Functionally, he has become completely dependent on others for dressing, personal hygiene, and feeding. He requires physical assistance even to sit up in the bed and has been largely chair-bound and has remained mostly homebound for approximately 2 years. On examination, patient was conscious and cooperative and was moderately built and nourished. There was no paler icterus cyanosis clubbing generalized lymphadenopathy. Mild bilateral pitting type pedal edema was present. His pulse rate was 90 beats per minute. Blood pressure was 90 by 50 mm of mercury in sitting position. Respiratory rate was 20 cycles per minute. Oxygen saturation was 96% on room air. The relatively low blood pressure in a patient with marked urinary and gastrointestinal autonomic dysfunction raises the possibility of associated cardiovascular autonomic involvement, although a formal orthostatic measurement would be useful further. So, this patient was conscious and was oriented to time, place, and person. Immediate, recent, and remote memory were essentially preserved. Attention and concentration were moderately impaired. His spontaneous speech output was reduced, but comprehension, naming, repetition, and reading were intact. Writing demonstrated prominent micrographia. His HMSC score was 28 out of 31, with errors in figure copying and the post office test and the recall test. His frontal assessment battery score was 15 out of 18, with mild impairment in similarities and lexical fluency. Overall, cognition was relatively preserved with mild frontal executive dysfunction. Cranial nerve examination showed preserved olfaction, visual acuity 6 by 18 in both eyes, with normal visual field, color vision, and fundus. There was no ptosis or nystagmus. Extraocular movements showed restriction of the horizontal gaze with broken smooth pursuits, while saccadic movements were relatively preserved. Pupils were equal and reactive. There was mild bilateral weakness of the jaw and facial muscles, with weakness of blowing of the cheeks and platysma activation. Hearing was clinically normal, palate was symmetrical, and gag reflex was preserved. Bilateral sternocleidomastoid and trapezius weakness was present. Tongue had normal bulk and power without fasciculations, although a tongue tremor was noted. There was no significant muscle wasting or fasciculations. The predominant abnormality was generalized rigidity involving all the forelimbs and the neck and the trunk, with bilateral cogwheel rigidity in the distal limbs. Motor power appeared reduced, predominantly in the proximal and lower limbs, with severe bilateral hip flexion weakness and additional weakness involving the shoulder, wrist, knees, and ankles. However, the presence of marked rigidity and bradykinesia makes interpretation of conventional power testing more difficult. The combination of extrapyramidal rigidity with pyramidal signs is an important feature in this case. The reflexes examination revealed a combination of brisk deep tendon reflexes and pathological reflexes. Jaw jerk was exaggerated, biceps, triceps, supinator reflexes were brisk bilaterally. Knee jerk was preserved while left ankle demonstrated sustained clonus. Bilateral Hoffman's and pectoral reflexes were present. Plantar responses were flexor or withdrawal bilaterally. Glabellar and the palmomental reflexes were present, while rooting, sucking, snout, and grasp reflexes were absent. Thus, there is a clear evidence of corticospinal tract involvement in addition to Parkinsonian syndrome. Sensory examination was essentially normal. Fine touch, crude touch, pain, temperature, vibration, and joint position sense were preserved bilaterally. Cortical sensory functions, including tactile localization, two-point discrimination, stereognosis, graphesthesia, were also intact. Cerebellar testing of the upper limbs was normal, with no dysmetria or dysdiadochokinesia. Heel shin test could not be performed because of severe weakness and rigidity. Overall, there was no convincing sensory or cerebellar syndrome. The extrapyramidal examination demonstrated a clear akinetic rigid Parkinsonian syndrome. There was a marked bilateral bradykinesia on the finger tapping, hand opening and closing, pronation supination, and foot tapping. The patient had hypomimia, reduced blink rate, hypophonia, hypokinetic dysarthria. Rigidity was generalized, including axial musculature. Anticolis, Pisa sign, and camptocornea were present. There was a postural tremors, but no prominent resting tremors. Several characteristic signs associated with other atypical Parkinsonian syndromes, including vertical gaze palsy, applause sign, striatal toe, and other cortical or dystonic signs, were not demonstrated here. Patient required physical support of one person to stand and walk. His stance was characterized by forward flexed trunk, relatively narrow base. He walked with the short shuffling steps at a slow speed with absent bilateral arm swinging. There was hesitation during gait initiation and multiple small steps while turning around. Because of severe postural instability and high risk of falling, formal tandem gait and pull testing was not performed. Overall gait was an akinetic, rigid, hypokinetic gait with freezing and marked postural impairment. Putting history and examination together, patient has a progressive multisystem neurological syndrome. The dominant clinical syndrome is symmetrical akinetic rigid Parkinsonism with severe axial involvement, freezing, and early postural instability. This is associated with prominent autonomic failure involving gastrointestinal, urinary, and sexual systems, along with the pyramidal signs and the bulbar functions. At the same time, cognition is relatively preserved and there is no definite sensory or cerebellar syndrome. So, coming to the anatomical localization, the clinical findings localized to multiple interconnected neurological systems rather than a single anatomical structure. Parkinsonian features localize predominantly to nigrostrial system involving substantia nigra and striatum. The brisk reflexes, Hoffman sign and ankle clonus indicate corticospinal tract involvement. The severe constipation, urinary dysfunction, and erectile dysfunction, and probably cardiovascular involvement indicates dysfunction of central and peripheral autonomic nervous system pathways. Bulbar symptoms suggest involvement of brainstem motor and bulbar networks. Therefore, the anatomical localization is multisystemic, which is consistent with atypical neurodegenerative Parkinsonian disorder. Coming to the major differential diagnosis is idiopathic Parkinson's disease, multiple system atrophy, progressive supranuclear palsy, corticobasal syndrome, and vascular Parkinsonism. Idiopathic Parkinson disease Idiopathic Parkinson disease is less likely because of the early and severe autonomic dysfunction, urinary retention, and rapid progression, early postural instability and prominent axial involvement, pyramidal sign, and absence of a typical resting tremor. And progressive supranuclear palsy is considered because of early postural and axial dysfunction. But there is no definite vertical supranuclear gaze palsy or characteristic vertical saccadic slowing. Corticobasal syndrome is unlikely because there is no significant asymmetry, apraxia, cortical sensory loss, or alien limb phenomena. Vascular Parkinsonism is also less likely because of progressive course and absence of significant vascular history. Coming to why multiple system atrophy. Multiple system atrophy is the leading diagnosis because of characteristic combination of early and severe autonomic failure with rapidly progressive Parkinsonism. In this patient, autonomic dysfunction began approximately 4 years ago with severe constipation, urine retention, and voiding difficulty, while prominent Parkinsonism developed approximately 1 year later. The subsequent development of symmetrical rigidity, bradykinesia, and early gait freezing, severe postural instability, axial abnormality, dysarthria, dysphagia, and pyramidal signs strongly supports multiple system neurodegenerative disorder. The absence of prominent cognitive impairment, hallucinations, or cerebellar dysfunction and cortical signs also supports multiple system atrophy. Why it is more likely multiple system atrophy P type, that is Msa-P. Multiple system atrophy is clinically divided into predominantly Parkinsonian phenotype, that is Msa-P, and predominantly cerebellar phenotype, that is Msa-C. In this patient, the dominant motor syndrome is Parkinsonism and marked bradykinesia and rigidity, while there is no convincing clinical feature evidence of cerebellar ataxia, dysmetria, or dysdiadochokinesia. Therefore, the clinical phenotype is more consistent with Msa-P or MSA with predominant Parkinsonism. So the final diagnosis here is the clinical diagnosis is rapidly progressive atypical Parkinson's syndrome, most consistent with multiple system atrophy Parkinsonian phenotype. The syndrome is characterized by early severe autonomic failure, symmetrical akinetic rigid Parkinsonism, prominent axial dysfunction, early postural instability and freezing, pyramidal tract involvement, bulbar dysfunction, and relatively preserved cognition without significant sensory or cerebellar syndrome. The underlying pathological process is most likely multisystem neurodegenerative disorder. Significantly, it can be alpha synucleopathy. Thank you for listening.